Welcome, everybody. My name is Paula Tusiani-Eng. I'm the founder and co-executive director of Emotions Matter. We are a 501c3 nonprofit organization that is to support, educate, and advocate for people impacted by borderline personality disorder. If you want to know more about us and our programs, such as peer support groups and education like this, I invite you to go to our website at www.emotionsmatterbpd.org. And tonight we're really delighted to have a webinar presentation on the topic of BPD and substance use, and a little bit about what to expect in this webinar. We're doing our welcome now, and I'm just really delighted to have all of you here with us. We're going to have a short presentation about on the topic of BPD and substance use by Dr. Maggie Davis, who I'll introduce in a moment. And then we're going to have a panel discussion with Alex and Kellin, who are two of our panelists tonight that will comment on this topic. And at this time, it is a great pleasure for me to introduce our speakers. And so Kellin is 24 years old and uses he, they pronouns. Kellin graduated from college with a bachelor's degree in social work and is currently a caseworker at Children's and Youth Services. Kellin aims to work towards gaining experience in the mental health field. As someone who has been through sexual abuse, emotional abuse, addiction, and suicidal ideation, Kellin collected many diagnoses over the years. However, the diagnosis that Kellin feels most impactful on him and others is borderline personality disorder. Kellin hopes to prove to people that there are positives of BPD, and we're so glad you're with us, Kellin. Alex uses pronouns he, him, and Alex is joining our panel from New York. Alex has lived experience with BPD, and Alex will share his experiences about BPD and substance use and how it has affected his life. Again, we're really happy to have you this evening, Alex. And Maggie Davis is a licensed clinical psychologist and associate professor at Yale University School of Medicine in the departments of psychiatry and psychology. Her research and clinical work focus on understanding and reducing risk for suicide and negative outcomes in people with trauma-related psychopathology, including BPD and substance use. She is the director of the Uplift Lab, Understanding and Preventing Loss After Trauma at Yale. Thank you so much. We're delighted to have you, Maggie, and we're going to turn it over to you.
Wonderful. Thank you so much, Paula. It is an absolute pleasure to be here and have the opportunity to talk about a topic that is near and dear to my heart, both personally and professionally. Thank you to my fellow panelists. It is an honor to have the chance to talk about this topic with you. Can you all see my slides okay?
Mm-hmm.
Always worry that when I'm on presenter mode that you're going to see the wrong side of things. So I appreciate you giving me that heads up. All right. So I like to start out with this graphic and be very conscious about sort of how I start off talking about BPD. I think this does a really good job of illustrating a couple of things, one of which is the complexity and extremity of emotions that are reported and experienced by people who live with BPD. I really appreciate that this graphic gives credit for the strength that it takes to manage and to regulate these emotions, and even characterizes that as heroic, which I personally really resonate with, and I think is often instead so stigmatized. Looking at this, considering the breadth of these experiences, I think really gives context to the complexity of this disorder. And in the context of today's presentation, therefore, kind of gives us context to understanding why we see such high rates of comorbidity with BPD. Because we do, right? We see a 96% rate of comorbidity with this psychiatric disorder overall. And that's with a variety of different disorders. So it's 96% overall, but with specifically substance use disorder, we see really high rates of co-diagnosis. So it's between half and 75% of people who are diagnosed with BPD have at least one current substance use diagnosis, with the most common being alcohol use disorder, followed by opioid use disorder. And that's just recently sort of taken over the second place with our opioid crisis in this country. So by contrast, interestingly, in samples of people who have a current substance use disorder, we only see approximately 25% of people who meet criteria for BPD diagnosis. I want you to remember that discrepancy, please, because I think it's important and I'm going to come back to it later. I think it speaks to stigma and some significant issues that we have around diagnosis and knowledge in our community about BPD and substance use and the relationship between the two. So to be just a little bit more specific, those with current opioid use disorder, cocaine use disorder, and alcohol use disorder are more likely to receive a diagnosis of BPD and vice versa. And again, these numbers only reflect substance use disorders. So we're not talking about substance use itself, we're only talking about the presence of the diagnosis. Substance use itself is likely much, much more prevalent in individuals with BPD. I want to take a moment here just to acknowledge some of the problematic terminology that is an issue in our field, and I think that is always important for us to consider. So those of you who, like me, are bothered by a general lack of symmetry, and I'm not sure that you can see my mouse here. Can y'all see my mouse on this? Okay. May notice that I've had to edit this diagram. This used to say substance abuse, because for a long time that was the term that we used. And thankfully, that's no longer the term that we use for diagnosing this disorder, because that term really tends to apply things like choice. It implies blame, right? It's problematic for a number of reasons. In a few minutes, I'm going to be bringing up the diagnostic criteria that we currently have for BPD, and I've tried to kind of rephrase them, but there's still some really problematic wording that we use for mental health diagnoses. In today's climate, in talking about things like BPD and substance use, which are challenging to treat, are incredibly challenging to experience, are challenging for people with lived experience, for family members, I think it's important to keep this in mind. But I digress. It's just something I always think is important to keep in mind and to consider in this space. So one way to approach understanding why we see these high rates of substance use in BPD is understanding why it is that substance use occurs in general. So to the extent to which we understand that. So what motivates substance use across populations and how those motives might relate to and be affected by the experience of BPD. So here are just a few of the most commonly endorsed motives for substance use. We see things like using substances enhances my experience. Perhaps it enhances my experience in social situations. It makes me feel like I can conform in a group situation. It helps me to cope with anxiety or with depression. It helps me expand my experience or my understanding, and it helps me to cope with withdrawal. And that motive specifically being in cases where you've already been engaging with substance use. Okay, so what do these motives have to do with BPD? So here are the 9 symptoms of BPD, spelled out again according to our most recent diagnostic manual. And just to break this down a little bit further, these can be subdivided a little bit more into 4 rough categories. So we've got kind of interpersonal symptoms, affective or emotion-related symptoms, and I like color coding. Y'all will see that throughout the presentation, so I've tried to make it a little bit simpler to understand that way. Behaviorally laden symptoms, and then symptoms related to self-image. Okay. So generally speaking, that's how we can break down how we're currently codifying BPD in terms of diagnosis. So let's look at these two things side by side, motives for substance use and BPD symptoms. So when we consider these things side by side, we can start to make some connections. Actually, we can start to make a lot of connections. Even considering one symptom, there's a lot of different arrows that you can start to draw. And in some cases, these will be direct causal relationships potentially, right? So for example, if we look at chronic emptiness, we might be able to draw a direct connection to expansion. So perhaps if I'm experiencing chronic emptiness, that might directly cause me to want to expand my experience, which might motivate me to engage in substance use, right? Some of these are going to be a little bit less direct, like for example, impulsivity might indirectly make it more likely that I'll engage in substance use if I'm experiencing any of these other motives, okay? But there's myriad different connections that we could draw between any of these different symptoms. So I went ahead and thought about these symptoms for a little bit, thought about all of these different motives, and tried for myself, and I would encourage you all to do this. Just kind of sit down, take a minute, and think about these symptoms and how they might affect any of these different motives and whether you think there are any relationships. Here's what I came up with, just breaking it down. Just off the top of my head, the connections are undeniable, okay? So just on the face of it, there are so many ways in which symptoms of BPD and experiencing symptoms of BPD might add to these reasons why we might engage in substance use, might be more likely to engage in substance use, and therefore might be more likely to be diagnosed with a substance use disorder. None of these are going to be universally true for every person with BPD, but generally overall, it's going to raise risk. And that's not all. There's other evidence that links BPD and substance use disorders at a more sort of general level. So we've got a growing body of research that suggested that both BPD and substance use disorders separately may be a result of childhood trauma, genetics, common family history. The childhood trauma relationship between these two disorders, not universally true, right? Not everybody who has these two disorders experiences childhood trauma or experiences it in the same way, but it is the case for some individuals. There's also commonalities, many commonalities, in fact, in terms of neurobiology underlying these disorders. So we've got the same brain areas that are consistently tied to the neurobiology of these disorders. So the frontal parts of the brain that are tied to things like motivation and attention, the limbic areas of the brain that explain emotion, that are tied to how we control our emotions and how our emotions are regulated, and the reward centers of the brain. All of those are consistently linked, and it makes sense if you think about the symptoms associated with these disorders. But all of those areas of the brain are consistently linked both to substance use and to borderline personality disorder. So they have a lot in common. And despite this, we still don't commonly see these two disorders being talked about together. We know there's a lot of comorbidity, and there's not a lot of treatment solutions linking these two disorders, right? It's not in the common parlance. Treatment programs don't commonly talk about it as ubiquitous, that individuals with BPD may experience substance use. It's not sort of something that's assumed. So why is that? There's a lot of reasons, but remember I noted earlier that a higher number of people with BPD are diagnosed with substance use disorders than the other way around. So it's absolutely true that this might be because there's a higher prevalence of substance use disorders than there is of BPD. That might be the case. It's also probably true that there are challenges with the diagnosis of BPD and receiving a diagnosis of BPD that are related to stigma. So I've been using this cover for a long time, and that's probably obvious just by looking at it. I think it's probably dated by the fact that it's got Barack Obama on one side and Steve Jobs on the other side. I have chosen to keep using this image and not update it because I think I am both disheartened and I think it's important to highlight the fact that we don't have to update it because it's equally true now as it was back in, I think it's 2008 when I pulled this cover image for the first time, right? Borderline personality disorder, the disorder that doctors fear most. This is still true. Many treatment programs for clinical psychologists, for psychiatrists, for more general medical practitioners still do not do a good job of talking about what borderline personality disorder is, how it's treated, what common comorbidities are for this diagnosis. What that means practically is that many individuals wait and are not diagnosed with borderline personality disorder initially, and so have to wait a long time to receive that diagnosis, and so don't necessarily understand initially, receive optimal treatment. If you receive a substance use diagnosis first, and you're experiencing BPD but don't receive that diagnosis, then you're going to be receiving treatment for the behaviors, but not for the symptoms that are driving them. And that's going to be a problem. Okay. So what can we do? How can we help? I had the privilege and the pleasure this summer, with support from the Fishman Family Foundation, to work with Emotions Matter and with Paula and some of our wonderful volunteers to run focus groups with some of you all who will hopefully be watching this webinar, individuals with lived experience of BPD and family members, loved ones of individuals who experience BPD and substance use, to ask, what have your experiences been like? What do you wish was different? What resources do you need? And we pulled some themes to try to understand what's needed. What can we be doing better? What can we contribute? And here's some of what we came up with and some quotes. And I'll say, I de-identified these quotes, took them away from people's language to make sure that they were as anonymized as they possibly could be, but still captured the spirit of the language of the participants who honored us with their participation. So the first thing that we heard over and over and over again is that we need to improve understanding of BPD in order to improve treatment of BPD and substance use both. So what the kind of quotes that we heard were, there's so much that's hidden. How do you know what's actually happening? And make the truth more known for those caring for somebody with BPD. And I think that's equally true for individuals who are experiencing BPD. The second thing is improving clinician and provider education. So we heard quotes like, when I was diagnosed with BPD is when I started to actually learn about what BPD was. I used drugs and alcohol to try to cope with my emotions for a long time before that. Okay. And then the third thing we heard about is there's a real need to develop and disseminate resources for families. And to do that kind of along two levels, educational resources so that you can better understand the experience that your family members and loved ones are having, and resources to help your family members and loved ones stay safe in the case that they're engaging in substance use. We heard quotes like, it's super hard to find support, and I wish I had support while my stepdaughter was still alive. So we're going to be engaging in a project over the course of the next year to try to develop these resources along the lines of these three goals. And that's part of the reason why we are kicking off that campaign with this webinar. And with that in mind, without further ado, I will stop sharing and we can kick off our panel. Thank you so much.
Thank you so much, Maggie. It was what a wonderful presentation with really easy to understand graphics about the relationship between substance use and BPD and the symptoms, and also giving us a lot to think about with hope about what we can do. And so I'm so excited after we have all this information to now have some incredible lived experience panelists with us to shed light on their experiences and a lot of, where science meets the real world. That's what we want to really bring to the table now. And so Alex and Kellin, maybe Alex go first. Tell us a little bit about yourself and your BPD journey. Tell us a little bit about when you were diagnosed and, what symptoms that you experienced.
Sure. So my name's Alex. My pronouns are he, him. I'm a licensed master social worker. I work in a middle school in Long Island, New York. And I was actually first diagnosed with BPD in middle school. But I really didn't come to terms with the diagnosis until earlier last year when I got the proper treatment. A lot of the symptoms I experienced were a lot of the things that we kind of saw in the slides. Relationship instability, very chaotic relationships. If it would feel like they start very intensely and they end the same exact way. These very intense feelings of abandonment. Always being worried that people are going to leave me. A lot of suicide ideations that come and go. Much more frequently than I feel like your average person with depression. And sometimes just feeling isolated from other people because I struggle sometimes to have like a strong sense of identity, like a sense of self. And sometimes it feels like I don't know who I am, no matter how many different things I try to ground myself in my identity. So that's a little bit about my journey so far.
Thank you, Alex. Kellin, do you want to introduce yourself? Tell us a little bit about yourself, when you were diagnosed with BPD, and what symptoms you have experienced or you experienced along the way.
Yeah, hi. My name is Kellin Bronwell. I am a caseworker at Children and Youth, and I'm from Pennsylvania, and I use he, they pronouns. I experienced, I was suspected to have BPD around 2018, but did not get officially diagnosed until 2022 because of the stigma. And I just have recently been diagnosed with substance use disorder early last year. I would say that I have experienced all 9 of the BPD symptoms. The ones that I struggle with the most are like fear of abandonment, impulsivity, suicide ideation, and unstable sense of self. I think I'm constantly worried that whenever someone says something that I feel like is unlike them, my brain will automatically like tally up the score, like, okay, like they said this, and they haven't responded to me lately, so obviously they're mad at me and leaving me. And I think that symptom has been the most harmful to the ones around me because of how I lash out at others and doubt people's sincerity. Um, Unstable sense of self is just painful all around. Like, I don't know who I am or how to be happy unless like somebody tells me how to do that. And then like everything's butterflies and rainbows. So I struggle with finding who I am aside from my intense relationships. And that's still a bridge I'm learning to cross. So that's a little bit about me.
Thank you so much. I really appreciate both of your candor and vulnerability in sharing a little bit about your internal experiences. So often with BPD, people see behaviors and they don't realize that, behaviors are connected to what people are feeling in the inside. That's too big to sort of manage and cope with. And so you both talked about in difficulty with relationships, intense relationships, identity. These are core internal experiences. And so thanks for kind of shedding some light and awareness on that. So we'd be really interested to hear, as Dr. Davis talked before about the relationship between substance use and BPD, what role have substances played on your journey? At what point did you start to have experiences with substance use to kind of manage symptoms, and why was that the case? Alex, you want to start?
Yeah, sure. So my experience with substance use, I feel like started around like my senior year of undergrad in college and like going into my master's. It mainly was just because I had no idea how to cope with all these emotions. Like everything felt so much more intense than everybody around me. I also wasn't open about having BPD. So I didn't feel like I could talk about it with anybody. And I also didn't really hear a lot of um people talk about like men having BPD. So I just felt very isolated and I turned to substances to try to cope with a lot of the suicidal ideations I was experiencing and the intense relationships that I was having. And honestly, it was easier to use substances than to try to find treatment. Because when I was going through my master's program in social work, there was not one positive thing said about people with BPD. A lot of the message I got was, "Don't work with these clients. They're impossible. They're manipulative." Um, so it made me just shut down even more. So I just turned to substances to try to cope with that.
Wow, what a difficult place to be in when you're managing you're managing symptoms that are so intense, and yet you're in school to try to be part of the solution to help others, and you're faced with all of these external messages and stigma. Thanks for sharing that and helping us to understand what that was like for you. Um, Kellin, when did you start to encounter substance use in your journey, and how did that affect you?
I started using substances also when I was in college. Um, I think I I don't like change. So the big step to like, because I lived on campus, so the big step to just moving on campus and out of my childhood home was a lot for me. And also I just like didn't feel like an adult, but I was like doing adult things. So it was a big disconnect for me, and I think substances gave me a way out of that feeling. Um, and whenever I would get sad, like the first thing that came to my mind is like something dangerous or harmful. Um, so I think I have to help bring myself down off of that ledge. And I think substances have been things in the past that have helped with those emotions and made it so I didn't have to do so much work.
Mhm.
Um, I could just sit back, and if something bad happens, I knew where to turn to. So it's definitely been a dangerous coping skill that I picked up, and I still struggle, facing things head on instead of creating that barrier so I don't feel those emotions.
Mhm. Yeah, I mean, again, thank you for helping us to understand that this was something that was to numb pain and to help deal with transitions and difficult phases of your life, whether you're in grad school, you're dealing with transitions, and you're dealing with some really hard stuff on the inside. That this was a path to sort of, numb pain and manage and get through. And yet you recognize that it was risky and could be dangerous, right? Um, and so as you went on in your journey and developed your own awareness of your mental health struggles, what strategies did you use to manage your BPD symptoms and or your substance use disorder? Alex, do you want to start?
Yeah, so definitely seeking therapy. That was like my first step in trying to get help for both PPD and substance use. And seeing a psychiatrist, I went on medication like antidepressants, which also helped make it easier to learn the coping skills and actually implement them. Like because when you're feeling suicidal all the time, it's very hard to have any hope that things can change. Also seeking out the BPD support groups through Emotions Matter, it was just so transformational for me. Being able to talk with people and hear other people's experiences who are going through the exact same thing as me, and to feel so normalized for the first time really in my life. So that really helped me tremendously get through a lot of dark times. And talking to family and close friends about my diagnosis, like finally opening up, having the courage to speak about it, and try to educate the people that I love, so that they can help me the best way that they can.
So you went from a space of feeling like, you had 10,000 bricks on your back, you were totally alone in grad school managing this, to being able to disclose and get help, get professional help, um, build a social network and support. Thanks for illuminating us about that. Kellin, what strategies did you use to manage symptoms and also your substance use?
I think it was difficult for me because the substance use started before I definitely knew that I had BPD. So like I was in therapy at the time, but it was difficult to it was just talk therapy. So like I didn't really know why I was feeling the way that I was feeling. Um, and every time I talked to like my family who, weren't as supportive at the time, um, they just kept saying like why aren't you getting better? Like you've seen so many therapists, like, and nothing's changing. So I think for me, I really had to find that love in myself and rely on myself, because I found that it was so much easier to rely on other people. So I think something that has helped me a lot is meditation. As cheesy as that sounds, but just anything that has will help me like regulate myself instead of always turning to somebody else, which I'm not saying turning to somebody else is bad per se, but I know that like I just always turn to other people, and I wanted to find that love in myself. So that was something that I really needed to manage and work through.
Hmm. We're all on a different journey, right? And wellness comes in different ways. And so I'm really grateful for this other perspective, right? That we can build a community, an external community of support, but we also need to sort of build that strength on the inside. And so thanks for kind of helping us understand that that's also a path forward. Um, and so, Alex, did you experience any barriers in moving toward recovery?
Yeah, honestly, I would say my biggest barrier was being a therapist with BPD in the mental health field. Because it was just very difficult to be open about my diagnosis. It still is. Like I wish I had the courage to even today be more open about it, like with colleagues and in the field, with the people I work with. But it's hard. Like it was ingrained in me throughout the program that people with BPD, like I said, like are manipulative, attention seeking. Don't work with them if you have the chance, don't. So it was hard to even come to terms with the fact that, you know, I was struggling with this and I needed help for this for this too. I also feel like there's a lot of when BPD is brought up, it's talked about as if it's like a personality like defect and like it can't be changed and that these people are just the way they are. And like to not get close with people with BPD. So just hearing all those things and the stigma surrounding the diagnosis, it just pushed me farther and farther away from getting help for it because I just didn't want to come to terms with the fact that this was me.
Mm. Yeah, I mean, the internalization of stigma is real, you know, and when you start to believe that all the external garbage, most of which is not true. It's just not true. It's all pejorative and uh, popularized by media and lack of education. But when you begin to adopt that negative narrative internally, it can be a huge barrier, you know, to wanting to even ask for help and disclose. And so uh, that is so, yeah. So you had a lot to deal with, and thanks for kind of sharing the impact that stigma can have on recovery. Um, Kellin, do you want to tell us a little bit about if you experience any barriers, what those might have been like?
Definitely relationships and self-esteem were my main barriers and still kind of are. I found that, and you know, I've said this before, but like whenever I am like single or I'm not like around other people, I tend to think that I'm healed. Um, but whenever like I'm in a relationship or have a really close friendship, I see my symptoms a lot more because I find that other person to regulate me. And I think that stems from my low self-esteem and not knowing who I am outside of how others perceive me. But other than that, like a big barrier that I've actually dealt with recently is just work. Like trying to work in an adult job and not feeling like I'm good enough for it. Um, that's been something that like I'm really trying to work through right now. So that's it's a big barrier, but it's one more step towards recovery. So
Mhm. Yeah, I mean, again, really appreciate your being vulnerable and sharing because, you know, there's so many barriers to getting on the road to recovery, and some are more systematic, you know, like access to care, finding providers, finding, you know, just basic, you know, basic healthcare when you need it. Then there's internal barriers, right? Like you said, you know, my self-esteem, my thoughts, you know, like that can be a struggle. And once you start managing symptoms and you're going back into the world, right, and building your life, there's every day going into the social world, you have to use emotions. And that means, you know, when you have a job, it's a job, but it's also navigating all these different social input every day and emotions every day and communications every day and getting up and having to show up for yourself. It can be very, very challenging to manage BPD and work and finding the right workplace environment. So appreciate, you know, you talking about some of those barriers. So in both of your cases, the substance use was not a true barrier. There were other, I mean, like once you worked through, it sounded like there were other things that you felt you identified as barriers on the road to recovery, not necessarily the substance use, which was one of the symptoms, you know. Um, and Maggie, when I'm finished, I'm going to allow you to, you know, respond. We only have two more questions. Um, and so, Alex, what advice do you have for others who may have lived experience with BPD? What advice would you have for family members who may have BPD and have loved ones that also may struggle with substance use?
Yeah, I think the biggest thing is just to know you're not alone. There's a lot of people that are struggling, maybe in the dark behind closed doors. Um, and don't be afraid to ask for help. It's never too late to get help. And it's never too late to talk about it with the people that care about you, the people that love you. And for family members, I would just say doing as much research as you can about BPD to try to end the stigma. If you hear other people talking about it in a negative way, chime in and stick up for the people that you love that are struggling with BPD. Um, I feel like a lot of times people with BPD are afraid to ask for help because they already feel like a burden, to the people around them. So just for loved ones, just showing compassion and empathy and just being there on the journey, I think means a lot.
Well said. No one is ever alone, and it's so important to be able to ask for help, but also to be surrounded by people who can listen compassionately and leave that door open and to develop understanding. Um, Kellin, tell us a little bit about what advice you would have for people with lived experience or family members.
For people with BPD, I just want to say that, you're valued and loved, and you're so much stronger than what your mind says to you. Just believe in yourself and love to the fullest, no matter what. Those who are worthy of it will stick around, and those who don't understand or refuse to communicate are not worth your time, and you deserve better. And try to find the good in who you are and celebrate yourself every once in a while because you deserve it. For family members and friends of someone who has BPD, my advice is also just to try to understand, do that research, have those conversations. Um, it's a group effort.
Wow, I wish that that clip could play back to people when they need to hear it, right? Because that's what so many times when people are at their lowest, they need to hear that, those words of wisdom from someone that's been there and understands. And so, Alex, how are you on your journey today? What does recovery look like for you?
Yeah, I feel like recovery is an everyday type of thing. I think, I might always be kind of in recovery mode, like just always trying to learn the best ways to cope with the things that I'm dealing with that relate to BPD and substance use. But today I'm just grateful that I got to a place where I can finally accept that, okay, this is a diagnosis that I have, but it doesn't make me less than, it doesn't make me hard to love. It doesn't mean I'm not worthy of love. So that's definitely something that I try to replay in my head. Um, and I feel like recovery just kind of means like acknowledging that you're struggling, reaching out for help, trying to do the work to be the healthiest version of yourself. So I feel like that's kind of where I'm at.
Thank you so much, Alex. Kellin, how are you on your recovery journey today, and what does recovery look like for you?
My recovery looks like just loving myself wholly, um, no matter what other people say, no matter what I've been through. Um, I've gotten better at speaking up for myself and understanding who I am and what I want out of life. Um, and I've been involved with a handful of people who've mistreated me just because they didn't understand. So I think, accepting that and moving forward is a really big step in my recovery. Um, and also just to soothe my inner child and be able to move forward in my adult life.
Thank you both so much for sharing a little bit about your journey. I want to give Maggie Davis, Dr. Davis, a little time to respond to what she's heard on this panel.
Yeah. Thanks so much, Paula. Alex and Kellin, thank you so much for being so open and for sharing your experiences in such a beautiful and genuine way. It has been a privilege to listen to both of you. Um, I've had a couple thoughts throughout listening to both of you. One is, I think we do something kind of, to my mind and in my judgment, speaking from a DBT lens, kind of paradoxical and nonsensical in our society, in my judgment. And that is, we encourage people to aspire to be exceptional, right? So that's what we idealize, being exceptional. But at the same time, we encourage people and we teach people to be normal, right? You should be normal. You should fit within a certain mold. And those two things can't coexist fundamentally. So you should be normal, you should be non-pathological, you should be the same, but at the same time, you need to be exceptional. You need to stand out. And it's kind of maddening, right? It's a difficult mold for anybody to fit into. I I point out the exceptional side of that. And Alex, it really resonated with me when you were pointing out in the context of your program that you're being encouraged to sort of fit into this mold, right? To function a certain way, not to point out the things that you were experiencing. And the things that for both of you, probably in the context of your work, that you have experienced and that uniquely equip you to be able to identify with the people that you serve as mental health professionals. Part of what I really value as a researcher and as a clinical professional about being able to work with people with BPD is the exceptional emotional insight that people with BPD often have. It's a gift. It's incredible. The ability that they have to identify with other individuals, the often incredible and exceptional artistic and creative insight that individuals with BPD have. I think we have this tendency to pathologize and not to appreciate the other side of things. And there's always two sides to the coin, right? So that's just, I think, something that I wanted to really sort of send home, that there is a beauty and a positive aspect to this. So I loved, Kellin, what you said about loving yourself, and really appreciating the beautiful and wonderful and exceptional and unique aspects of yourself. The other thing that I really wanted to highlight here that really resonated with me that I heard in some of what both of you said was substance use was in part motivated by the fact that you had things that were real and impactful that you had to cope with, and there weren't resources available, right? There wasn't treatment available, and had there been treatments available, it would have mean seeking out resources and telling people about it in a way that wasn't necessarily safe because there's so much stigma. I really appreciated you sharing that and shedding some light on that because I think it's such a huge issue. We need to do a better job as a field in talking about BPD, talking about people with BPD as the exceptional humans that they are, the valuable members of society that they are, not using the unacceptable stigmatized language that we've been using.
Thank you so much for those insightful comments. It has been a pleasure to have this incredible panel this evening. At Emotions Matter, we believe in talking about important topics in BPD from a lived experience perspective with multiple stakeholders always at the table. So at our roundtables, we are always going to have, clinicians and experts in the room sitting at the table with people with lived experience and having this dialogue together so that we can really have deeper understanding and learn from each other. And I truly learned so much from you, Dr. Davis, tonight. And I also learned from Alex and Kellin so much more about your experiences, and that helps me come to a deeper awareness and understanding of BPD and substance use, as I'm sure many people who are listening also felt that. And so I want to thank everyone who came to our webinar this evening. We hope that you also benefited from this experience. You can feel free to go to our website at www.emotionsmatterbpd.org to continue to look for more educational content such as this. We hold webinars every quarter. We'll be having a new series coming up in April and May for BPD Awareness Month. We also are a nonprofit organization that exists because of family members, individuals with PPD, and community members who are donors that give to help us support our mission to be able to provide free peer support groups for people with BPD so that no one feels alone with this disorder and that people can get connection when they need it. And we're able to provide, several thousand people a year with free peer support because of the generosity of our donors. So again, you can feel free to go to our website, make a donation at www.emotionsmatterbpd.org. Thank you again for your time tonight, and we will see you at the next webinar. Take care now. Thank you.